seniors for medication reduction services and medication management service. I will say that this pandemic has changed the environment of caring for the elderly dramatically. And so I just want to talk for a few minutes, this is my first time doing a 15 minutes CE program. So I started my timer just now to make sure that I don't end up trying to do an hour CE program, because that's what my brain is programmed to do. So let's get through I have no conflict of interest. I can't wait for the day when I get to announce a conflict of interest. But I have no conflict of interest here. We're really not going to be talking about a significant amount of drug therapy. I'm not going to talk about any individual products. What I'm going to be talking about more is the process and the interaction with the elderly during the COVID pandemic. So here are the objectives for both pharmacists and technicians. First is to recognize the barriers to chronic disease state management and review very briefly some strategies for self-management of 3 specific problems: hypertension, diabetes, and pulmonary disease. Secondly, I'll talk about the impact of isolation on the elderly. And this is something that isn't just specific to the COVID pandemic. People with, elderly patients are isolated normally. And so when you add on top of this the mandatory isolation that comes with the pandemic, then it's just an extra layer of isolation where a lot of the support structures that they normally have just been knocked out from under them. And then what can pharmacists and technicians do to assist with those issues? And then finally, we recognize the impact of isolation among the elderly on mental health, including depression, insomnia, and dementia. So I'll start with the pre-test question. And so which of the following represents the classic screening questions for early stages of dementia in the elderly? So the first choice would be, what's your favorite color? What's the name of your first pet and where were you born? And then the second choice is, what's today's date? What's the name of the town where you live and who's the president of the United States? The third, what's the name of your mailman? What's your favorite food? What's your email address? And then finally, what's your favorite TV show? What's the name of your best friend? And what did you have for breakfast today? So I think I see, Starlin, maybe you can help me out here by getting into the chat for me. And
all right, so it looks like people are picking B.
Yeah, right. So the reason that B is the right answer is that these are factual answers. These aren't opinion-based answers, or even some of the ones that are factual, we don't have any way of knowing if they're true or not. Right. And so that's why you always, those are the classic triad of questions. And I had a patient last Friday that I asked him, and it was our first Zoom meeting. He was a man that he was in his 90s, and I've been seeing him for years, but this was our first meeting on Zoom together. Wow. And it had taken a little time to get it set up, and I think his daughter, who is a part-time caregiver, kind of got him set up there. But when I was doing my mental screening, I asked him, what's today's day and date? And he told me, and I thought, is that right? Because I'd been in my own basement for so long that I'd completely lost track of the time. But so that's kind of the classic questions. So let's start with the chronic disease state management. So right now we have, before the pandemic and before the forced isolation, we had a lot of problems with chronic disease state management in the elderly. There are a lot of misconceptions about medicine. And when I'm talking about the elderly, I'm talking my general patient population is about 80 years old and up. And there are, especially among the men, a lot of reluctance to take medicine. They many times don't trust medicine. They don't feel like they are, they don't like to admit they're sick, because if they admit they're sick, then they're sick. And we have data, this isn't just my opinion, that women are much more likely to follow the recommendations of physicians among the elderly than men are. And I want you to guess what the #1 indicator of whether a man will be adherent with his medicine after age 80. What do you think the #1 indicator of whether he'll actually take his medicine will be?
If he's married?
if he's married. That's right. And so those things don't go away. But we have additional problems because of the pandemic, where we have reluctance on the part of the patients and the providers for the elderly patients to come into their normal care environment, because the elderly are most at risk for the COVID infection and most likely to die from it. Then they are being urged to stay home for their chronic disease state management and use telemedicine options. Well, when we move to telemedicine options, there are age-associated barriers to utilizing those options. Many of my patients that I see do have home internet. However, I will say that the speed of their internet maybe hasn't been updated in the last 10 years or so. And so when you start using video conferencing, then the lag time gets really bad. And so that's our hurdle to get over too. Then also, when you're using telemedicine, the basic hands-on skills of patient care are just eliminated. I had a patient 2 weeks ago, an elderly woman that had a chronic cough. And now this cough far predated the COVID pandemic, but she was experiencing muscle pain. And normally I would palpate her and like poke her with my finger to see where it hurts. Well, you can't do that with telemedicine. So what I had her do was do it to herself, and just like, okay, poke yourself in the shoulder, now work your way down your ribs. And then when she got to the third intercostal space and she went, ow, I'm like, okay, now I know what it is. But I had never in my life had a patient palpate themselves when it was something that I would normally do, myself. And then maybe the biggest hurdle that we're facing right now is the lack of point of care objective data. If they don't have a home blood pressure monitor, then you don't have a blood pressure. And how are we supposed to do dose adjustments for their blood pressure if you don't have the home blood pressure monitor? Their A1C, their glucose, all of those, the point of care objective testing we normally do just isn't available. So what do? Well, we get them home blood pressure monitors, we get them home glucose monitors, and we teach them how to use those. And then also for pulmonary disease, the peak flow monitor, and being able to utilize that maybe less than ideal, but not nothing objective data, and working with the patient to come up with their comprehensive care plan so that they can adjust we can adjust their medication, or they can adjust based on, what our treatment protocols are, without them necessarily coming into the office, okay? Now, one of the things I'm worried about before I move on to the isolation portion is, when will we bring the elderly back into the clinics, okay? Because this is, again, a very high risk proposition. And I spent some time, reading the governor's plan today. That certainly was better than what we had before as far as details. But we really are going to have to be very cautious in how we reintegrate the patients. Let's look at it from the patient's point of view. Many times, at least in my patient populations, their transportation to the clinic is a van that shows up. It isn't like a town car that comes and just takes them to the clinic, but it's a van that pulls up and it goes to 6 or 7 or 8 different homes and takes all the patients there for an appointment in one day. So we're already gathering the people that are highest at risk together. And then once they get to the clinic, they're highly at risk as well. I don't have an answer for that, other than the fact that I think the elderly are going to be further delayed in the return to the natural clinic environment, the traditional clinic environment, as opposed to younger patients. Let's talk about the isolation a little bit. So most of my patients that I see currently are widowed. About 80% of my patients have either lost their husband or wife, and they live alone. Many of them, the tragic kind of catch-22 of the successful elderly person is their children They worked really hard to put their children through college. And then their children got a good job in Houston or Seattle or wherever. And so even their family members are kind of giving them long distance care. So then you get these replacement families, the churches, the senior centers, the senior field trips. So these are like bus trips where they go to restaurants or they go to the plays. Maybe I would, right at the top of the list are the beauty parlors and the barbershops. The number one reason I have for a patient canceling my home visit is an appointment opened up at the beauty parlor. And so what you have for me is less important than that. And I mean, I go to a barbershop. I did before this. My wife cut my hair the last few weeks now. But, you know, that level of discussion is important. That level of interaction and camaraderie that people have is really important. And those things have been severely impacted for our seniors. And then there are some programs that have continued that would limit exposure. I get significant number of my referrals from home health agencies. The other portion just come from word of mouth. And home health visits for the elderly right now are limited based on what the diagnosis is for that patient. Because again, they don't want to, if they don't have to go into the home, then a home health nurse goes from house to house to house, or the home health pharmacist or the home health social worker. And so we're trying to limit that. And then one of the more important ones is Meals on Wheels. The meals are still being delivered, but traditionally a Meals on Wheels program, the ones that I've worked with in Southern Illinois anyway, will schedule visit time when they drop off the meals. And it's normally about a 15-minute visit time. And that is an important daily interaction where people who aren't healthcare professionals but have been trained to recognize problems can sit down and visit with them for 15 minutes every day. That's been eliminated. The meal's still being delivered, but they're being told that no more than 15 seconds is the time that you spend in the patient's house. Drop off the meal and out the door. So we just need to be cognizant of that and do what we can to, you know, make sure that we're assisting with the isolation that the seniors are feeling. If they have an Apple device, a shocking number of the very elderly are very familiar with FaceTime because that's how they communicate with their grandchildren and great-grandchildren. So that technology is simple to use. I will say that I've been really surprised and delighted by how many of my senior patients are able to set up Zoom. We just walk them through the process over the telephone. It's really straightforward, and then we're able to use it. The one thing, the difference between the two is FaceTime is not encrypted and Zoom is encrypted. And so I prefer to use Zoom if I can, just for privacy issues. I have a statement that I have a patient repeat back to me at the beginning of the meeting, just saying, you know, they recognize we're using distant technology and it's possible that we could be, their private information could be inadvertently shared. Most of the people don't have any problem with that. And the last thing I'll say, and it's super easy to do, the very elderly love handwritten letters and cards. It's something that comes as often as they can. They get delighted by it and they feel really connected with it in a way that I think people of younger generations maybe have lost. And that doesn't take a lot of time or effort to send things out. Even if it's to, you know, if you just do a search on your patients in your community pharmacy that are 85 and above, and even if it's kind of a form letter that you send them, but something that's coming that recognizes that you're there for them would be of use. Okay, moving on to the mental health issues in the elderly. The elderly are already at increased risk for depression. There are different rates between men and women. Again, men, if you've been married for 30 years or more, men that lose their wives, their health dramatically drops. Flip side of that coin is, if you've been married for 30 years or more, women who lose their husband, their health dramatically improves over the next year or so. Men tend to be either dead or remarried within a year of losing their wives, whereas men tend to grow close personal friendships with female peers. And that men just don't do that. Elderly men have a much harder time doing that. So because of this increased isolation, because of the loss of their spouse, then depression is much more likely. And again, take away their support systems. Depression is more likely to present as physical complaints in the elderly as opposed to younger people. So back pain, stomach aches, shortness of breath, chest pains. Okay, so non-traditional chest pains where it's not radiating to the left arm, not a crushing chest pain, but more like a heartburn type of pain. Think depression in the elderly when you hear that. And then again, depression is associated with isolation. So a few things that you can talk to people about their depression. One question I always like to ask my elderly patients is, what activity do you enjoy and how often are you doing it? Okay. If they say, oh, I enjoy whatever, I enjoy making puzzles. When's the last time you put a puzzle together? Oh, 2 years ago. Well, let's do some puzzles. Okay. So trying to get them to engage. I had an elderly patient, a couple. He was 93 and she was 91. She was my patient. This one I was actually in their house doing a home visit. And I asked her this question and she said, oh, I love to go dancing, but we haven't gone dancing in years. And her husband got down on his knees and hugged her and said, oh, baby, we'll go dancing tomorrow. And I thought, my work here is done. Everything's better now. But just trying to make sure that they not only know what they enjoy, but they're engaging in those activities. And then if you suspect things, say, how much time are you spending about things from your past that you regret? And how much time do you spend thinking about things you've done in your past that make you proud or happy? And trying to move them from thinking about their regrets to things that they're proud of. And sometimes that's a gradual, slow process, but it can be done. Sorry. Okay, insomnia, again, more common in the elderly. I don't know what you guys think right now. Insomnia is like my #1 personal problem with this, with the clock just going out the window. A lack of a typical schedule can contribute to daytime sleeping and a lack of quality sleep at night. And so some of the questions you can ask people are you napping more than normal during the day? How often are you waking up during the night? And are you having trouble falling asleep or trouble staying asleep? Again, these are screening questions. We would ask more in-depth questions to help guide drug therapy, but I'm very reluctant to use drug therapy for insomnia in the elderly if we can avoid it, because almost everything that you can use for insomnia is associated with increased fall risk, and that's going to be, you don't want them falling in the bathroom when they have to get up to urinate at night. So sleep hygiene. This is for everyone, not just for the elderly. Avoid screen time for 1 hour prior to bed. Okay, sure. But it makes an amazing difference. Avoid reading, snacking, or watch TV in bed, regardless of the time of day. So your bed is for sleeping or for sex. That's it. Nothing else. And people shouldn't be using their bed as a lounge area. Noise disturbances, if the noise disturbances cause awakening, then first try to address the noise disturbance. If it's a neighbor or whatever, talk to them about it. And then if that doesn't help, then white noise, just like what we used to tell people, and my patients still have just a classic radio that you tune to static and turn it down to a low volume and creates white noise, which they can help them sleep. And especially important for the elderly is emptying their bladder immediately before bed. And then taking no diuretics, especially after noon. Now, certainly loop diuretics in the elderly should be taken first thing in the morning. Even thiazide diuretics, when we lose most of the diuretic effect over time with them, but there is still a mild continuing diuretic effect. So as we know now, if you take multiple blood pressure medicines, one of them should be at bedtime. That one at bedtime should not be their diuretic, regardless of the type of diuretic that they take. The most dangerous thing an elderly patient can do in their own home is to get up to urinate in the middle of the night. Some people, we can't get them to 0 instances, but we want to minimize that as much as we can. And then avoid taking naps during the day, especially after 3 p.m. Okay, so dementia. We know in early stages of dementia and all stages of dementia, frequent, consistent mental stimulation is important. If you take away their environment, their support system, then that frequent, consistent mental stimulation goes away. Two things that have been shown to be useful are puzzle games such as Sudoku and crossword puzzles. They get your brain working. Even I've had some patients will just sit down and do arithmetic. They'll just sit down and do math problems. They will go to the library and check out an 8th grade math textbook and sit down and work through those problems. And it stimulates their brain in a way. Any brain stimulation has been shown, especially in early stages, to slow the progression of the dementia. And then we really have to be cognizant of the people who are in early stages of dementia, who are elderly and living alone, because they can slide off that slope really quickly, and we need to be able to catch them early, because if it's time to move into assisted living or specialized care facility, then it's time. One of the things that I discuss with all my patients is not if you will move into assisted living, but when will you move into assisted living. And in the same way, we no longer punish patients with insulin. We don't punish patients with assisted living either. You try to sell them as it's something that's exciting and it's, you know, clean, and you have friends there and there's lots of stuff to do, as opposed to, oh, you're leaving the house that you and your husband built 50 years ago. Okay, the way that you approach it with them is very important. So dementia screening, calling them regularly, and then the classic dementia questions that we talked about before. Today's day and date, do you know the town where you live, and know the name of the president of the United States? Any of these questions need to be fact related, not opinions, and facts that you can verify. Okay, I went a little bit over and I apologize, but we got through a lot of information, I hope. So what questions do people have?
Thank you very much. Don't worry about going over. It's great information. If you have a question, please type it in the chat box, or if you want to hit on the participant button and hit raise your hand, we'll be glad to recognize you. Laura has a question about, should this be implemented as a quick screening tool in community pharmacy?
I think sometimes community pharmacists, and I was, when, you know, my first several years in my career, I was a community pharmacist. I was sometimes reluctant to ask people mental status questions because I felt that they would find it embarrassing. And I think the way to look at it is, if you're not embarrassed, then they won't be embarrassed for the most part. The same way about talking about sexual dysfunction or sexually transmitted diseases or whatever. If you're embarrassed, they're going to be embarrassed. But if you're not, then asking those types of questions, many times people are really willing to be open. So yeah, I think that it's a good idea. And just like, do you know today's day and date is such an easy question to ask them. Even sometimes I'll pretend like, oh, I'm writing my note, and I'll look at them like, oh, do you know today's day and date? And as if I'm writing it down. And rather than like, aha, do you know today's day and date? Like, just ease it in a little bit more easily. What else?
There was another question about, did you say that heartburn is associated with isolation or depression in the elderly?
Okay, so non-traditional symptoms of depression are more likely in elderly patients than in younger patients, okay? So feeling like heartburn, but it's more like, you get that feeling like you've been startled or like impending doom, where you just kind of feel an emptiness in your chest, as I've had many patients describe it to me. So it's not a traditional heartburn. It's not a link between heartburn and depression, but just kind of that vague feeling of disquiet in your chest, which some people may mistake for heartburn, is more likely to be depression in elderly people than it is in younger people.
Okay. They said thank you for the clarification.
I see that one.
Yeah, you saw that one, yeah.
I will say that that's the one that most people will try to fill in with a joke. But I'm okay with people answering with a joke. I'll circle back around to it. I'm like, okay, but do you really know who the president is? Because sometimes people will say kind of jokey things in response to that. Okay, so I think we have, oh, someone raised their hand.
Abby. Oh, yeah, we got Abby's raised her hand here. Hang on one second. Abby, go right ahead.
Me okay?
Yes, I can hear you
Yeah,
now.
you're good to go.
Yeah, thank you. Thank you. Appreciate your presentation. That was
Okay.
excellent. My question is, have you noticed that there is perhaps more need to do telehealth given the current situations? And have you noticed there's a difference between telehealth and in person when it comes to this vulnerable population?
Yeah, so look, there's no substitute for sitting at someone's kitchen table and getting out the giant box of medicines that every home in America has and digging through it. And when we talk about their diet, going and opening the refrigerator, you know, when a patients tell me, oh, what did you have for lunch today? Or what do you eat for lunch? And they tell me, well, I eat salads every day. And I go open the fridge. I'm like, there's no salad in this refrigerator. There's only 2-liter bottles of Mountain Dew in your refrigerator. You know, so I love home visits. I find it to be an honor and a privilege to be invited into my patient's home. And I have what every real pharmacist, I'll say it that way, you know, a traditional pharmacist will be aghast at the amount of time I spend, because my first visit with a patient is an hour and follow-up visits are 45 minutes. And if I need to stay 2 hours, sometimes I will. So I have the luxury of time and place. In telehealth, I'm not in their home. And so they're already, it's closer to being in the office because they've gotten ready for this. This is an event for them. The other thing I will say with telemedicine is if you have time, people are so isolated and alone. If you can schedule an extra 15 minutes to just chat with them before you get into the meat of your discussion, then people really appreciate it. And it's really difficult for some of them at how isolated they are. So yeah, it is a poor substitute for sure, but it's better than nothing. And I will say using like Zoom technology is way better than the telephone, because that face-to-face is super important. You can get way more information that way than just talking to them on the telephone.
So Chris,
Thank you so much.
who's your payer?
Nope. So when I'm the least cost-effective clinical service in the world. When I am referred through the Visiting Nurse Association, I worked with Southwestern Illinois Visiting Nurse Association, which has been a nonprofit since 1917, since the original epidemic in the United States. They've been in operation since then. They write off my time as a charitable donation. But other than that, this is a free community service of the university. And I will say that without apology, because in my 27 years working in academia, kind of pushing the boundaries, that's where the proof of concept often is. But look, when I cover 5 counties, and many times I drive an hour between visits. So yeah, there's no payer, Starlin. My students are the payers. Their tuition is.
I was given a presentation to the city of Chicago, and one of the union leaders said, well, you spend all this time with the patient. We're not paying you to chat and babysit.
Yeah.
And that's how they start communicating with you. I'm really frustrated with pencil pushers who don't understand that chronic disease is chronic and you can't get 10 lessons and you're cured. And the reason why we have so much issues in as we get older is that you can't fix everything with acute care remedies. And
well, even the charitable donation write-off has been questioned several times.
I'm sure that's what I get audited on.
Yeah.
Is when I do things around Springfield for free. Yeah.
So let's move on to my post-test questions. I think we need to get through these real quick. and I'm not sure where the yellow lines are coming from, but it's not really important. So what are some of the basic components of sleep hygiene for seniors? Avoiding screen time for 1 hour prior to going to bed, not eating, reading, or watching TV in bed, and avoiding taking naps during the day, or A and C only, or A, B, and C. And
You have an E, answer E.
yeah, of course the answer is E. All of those have been shown to improve insomnia. The other thing that I didn't mention for insomnia that is important in the elderly, and I have a list of books that I can share, is just some basic meditation techniques that I've found. I don't have any clinical evidence that they work. I've got a decade of personal experience that they work for people that try it, just some breathing exercises and that sort of thing. And they're really kind of like introductory meditation techniques that I share with some of my seniors, and I'd be happy to share those with you guys as well. And then the second post-test question, which of the following are hurdles faced in caring for the elderly during the COVID-19 pandemic? So lack of access to much objective data, seniors' lack of familiarity with distance technology, or seniors are too busy to deal with their healthcare right now. And then A and B only, or A, B, and C. And
I got a D.
yeah, lots of D's. Yeah, so yeah, the answer is D. It's not that they're too busy. As a matter of fact, they're desperate for things to keep them busy. Here's my contact information. Email would be preferred. Is anything else that related to this before we get into the rest of the town hall? Well then, thank you all very much for your kind attention. It was an honor to present to you this evening. Thank you so much.
Thank you, Chris.
Thank you very much, Chris. And I'm going to pause the recording so then we can shift over to the code real quick for everyone. Okay, we've restarted the recording. And as always, as we're getting now into the town hall part, remember, we're doing a good job of keeping our microphones muted or your phones muted when you're not asking a question. If you do have a question, you can raise your hand, and you can also use the chat feature. And remember, this is your time, and I do have a couple things I do want to go over, just updating on stats like we have every week. And then I wanted to dive in a little bit into the Restore Illinois program that the governor announced yesterday, in case a lot of you have not had a chance to dig into it yourself. Here, hang on one second. All right, as you can see for this week, we've now are 3.7 million cases around the world. We are 1.22 million cases. I think one thing of note here is how much more the population is being tested. We still have a number of deaths, but I think as we continue to improve our treatments and try to keep people off ventilators, we're definitely impacting and starting to flatten the curve. I think with the case load with where we're at right now is showing that this is actually working. And a lot of the sacrifices that we've have endured the last number of weeks and months have definitely helped keep us into a less favorable situation as we would have been in. Illinois, we are now at 68,232 cases. Again, we only have about 4 or 5 counties that at this point have not had a single case. We are just under 3,000 deaths. There is some evidence to show that the state is starting to flatten. I think a lot of that is shown by the decrease in the requirement on hospital beds and ICU beds, and that's what the department's been focusing on in the last number of press conferences over at least the last week. Testing is ramped up. The governor did meet, was able to help get the state to meet his goal of 10,000 COVID-19 tests per day by the end of April. And I think that number is now over 15,000 tests per day, which is amazing. And I think that number will continue to dramatically increase over the next month to 2 months. McCormick Place is being scaled back and in the processes of being phased into being shut down, which I think is wonderful. I know a lot of people are giving the governor a little bit of heat for that, and I find that interesting that a lot of people are giving the government heat for not using something and that the situation didn't completely blow up and turn completely bad. I think it's better that we were prepared to have 4 field hospitals in the Chicagoland area and had primed an area in the central part of the state. And luckily, we didn't need it. As we see with our social distancing, Illinois actually improved. Not very much. We're still C-, so we're still below average. And as you can see here, you can see which counties are doing better than others. You can see some of the top counties. None of the counties reached above a B, at least in the last week. So it is still important to show that social distancing is working. I think as we start to definitely see, as we now have 43 states, including Illinois, that are in some phases of starting to open back up and start to go down that road of back to normalcy, whichever we'll call that by the time we're done. I think we'll see what the impact of which strategies work best. I did want to touch on a couple of things. We did touch on this a couple of weeks ago, that PTCD is offering online proctoring for the exam. This is the first time that they have allowed that. Usually it's been in-person testing centers like we do for the board exam. So the candidates have to have a computer with a webcam and a reliable internet connection, and must be in a quiet space where they'll be uninterrupted. And PTCD is actually offering it for all the exams. Remember now, there's other specialty exams beyond the traditional CPHT exam, and they are offering really reduced rates for the exam between now and the practice exam through the 31st. So that's good for news from PTCD. NHA finally did do some announcements this week after they had a webinar where they're also offering a live remote proctoring, and again, very similar recommendations on scheduling online to be able to do the computer with a webcam and an internet connection. And before I forget, there are some upcoming government meetings of interest. Next Monday is the Collaborative Pharmaceutical Task Force. We did not meet in April, but we decided to, our chair, Phil Burgess, has decided to keep trying to push forward. So we're going to do a WebEx call. And this is the information here if you wish to attend. And the Board of Pharmacy, for some reason, they're having you email the board liaison for access to the information. Not quite sure how that meets the requirements of the Open Meetings Act, but that's the process that they're going through. So if you're wishing to reach out to the board, to attend the board meeting virtually, you need to email Robert Gurton at robert.gurton, and that's GERTON @illinois.gov. And if you have any interest in attending either one of these and need some assistance, please call the office and we'll be glad to help you out with that as well. And let me shift over to my slide deck for the recovery plan. I took these slides. I made these today based on the governor's actual report. It's called Restore Illinois, and actually from some great graphics that the Chicago Tribune did, and from their article as well. So the governor has announced and released yesterday a plan for safely opening the state called Restore Illinois, and it's essential. It's in a five-phase program, and it's going to have a regional approach, which has been pushed by a lot of members of the General Assembly, some organizations, and some members of the public, and which kind of makes sense as a wide area and varying demographics of the state. The state has been carved up into 4 regions, and I believe these are being based on established EMS regions for the state. And the numbers you see there that go all the way up to 11, that's the areas for the Illinois Department of Public Health regions. And so the Chicagoland area is what's called Northeast area. And then you have Northern and Northwestern, which is the North Central area. Springfield area, all the way over to Quincy is considered, or actually from Quincy all the way over to Champaign is considered central. And then everything just above and below 70 is considered southern. So there is going to be a 5-phase plan, and it's basically, and I'm going to go into this in more detail. There's the rapid phase, the flattening, recovery, revitalization, and then what's called Illinois Restored. And a lot of it really focuses on hospital capacity and testing.
Good job.
And then ends with treatment. Again, these were from the Chicago Tribune article, and it was really great to put these into categories.
Anything in there might get washed, so don't put
things out
marshmallows.
to make it a little bit easier to understand.
That's good.
So for healthcare, it's basically healthcare phases is kind of where we were. We're in phase 2 is where the governor is saying we are now. So that's why these notes starting on Monday, elective healthcare procedures can be performed. Phase 3 is that healthcare providers are all open with department approval. It seems like they're being a little bit more lenient on that right now in phase 2 for some. Public gatherings is where it's going to get a little confusing. So right now we're in phase 2 where it's essential gatherings must be 10 or fewer, no non-essential gatherings. And then phase 3 is all gatherings, but still 10 or fewer. Phase 4 will be 50 or fewer, following any state or CDC guidelines. And then phase 5 is large gatherings of all sizes can resume. This is where big questions about big events such as festivals, conferences, and such, even the Illinois State Fair, or I know one of the questions yesterday was on Lollapalooza. It doesn't look like some of those major events will be happening this year, just because of how they determine the definitions for these phases. Schools are still going to be in remote learning as they are now, and even in phase 3, there'll be some remote learning. And not until phase 4 will there be some, all schools and universities could be open. And even in phase 3, there were some limitations in the question and answer about smaller class sizes may even be looked at. So restaurants and non-essential businesses, again, non-essential businesses are still going to be closed up until phase 3 where they can start to return to work pending guidelines. Essential businesses are open with restrictions, basically how they're being operated now. Manufacturing is going to be based on the industry, and non-essentials aren't going to be able to really re-engage up until into phase 3. Travel is basically what it is now. Try to limit your travel as much as possible, and then up until phase 3 will all travel be allowed. I think one thing that was interesting is how they're looking at the phases. They're taking a longer approach of 28 days in a region of the state. Like we just talked about those 4 regions before that region can move into the next phase. So the governor is saying that no region in the state can even look at being moved to phase 3 until the end of May. And that kind of goes against a lot of what the national guidelines and even Dr. Fauci has been saying about that these guidelines can be looked at as, say, 14 days. The state of New York is using 14 days. So there may be some revisions to this plan as scrutiny is and different groups are taking a look at this. Outdoor activities and entertainment venues. Have you seen state parks and activities? Some state area parks are open now, but it even limitations now on water activities and golfing. Entertainment venues, it says closed, but they did make a change that drive-in theaters, for those that, were fortunate to still have those, entertainment palaces in and around the state, they're still are going to be, they can start being used as early as this Friday. To kind of show you really what they're looking at, phase 1 is where we were, rapid spread. And so we had new case growth, hospital and ICU beds, or, it's difficult to handle. We want to make sure we're really limiting a surge aspect and trying to get to those 10,000 tests per day. And this basically shows you what the government decided this is what they were defining as what had already happened, because now they're saying we're in phase 2, which is flattening, which new cases are at or under 20% positivity rate, which I think today they said was 15% at positivity rate. And that increasing testing available for patients, healthcare workers, first responders, and people with underlying conditions, and residents and staff in assisted living facilities, which we know is a major area of concern right now. We have assisted living facilities throughout the state that are just bastions and hotspots for COVID right now. And I know that there was a comment in the chat about limitations of admissions to some of these facilities. I think some nursing homes are just trying to make sure that they can protect their existing population before they add in additional people at this time. And it seems like the long-term care guidance is changing on a weekly basis from the board. Phase 3, again, is moving into recovery. Again, it goes to more testing is now available in the region regardless of symptoms or factors, and that's just going to be based on how quickly we can get testing up. And they're wanting to make sure that we can begin contact tracing and monitoring within 24 hours of diagnosis for more than 90% of cases in the region, which is going to be a pretty big operation. And that's why I think for some people, it's going to be hard for a lot of these region areas to move to phase 3 just because of capacity, just for testing and for tracing capacity. I think that's going to be a major issue. And the state hopefully needs to start looking at some alternative ways of looking at addressing those issues. Phase 4 is revitalization. Again, it's saying that new cases, vaccine and treatment, or the elimination of new cases over a sustained period of time through herd immunity or other factors. I'm glad there's 4 here, because this is going to be hard to obtain to move to revitalization stage, at least in the current environment, until we get some positive traction on a viable treatment and or vaccine. And it's really going to be based on the herd immunity and elimination of new cases. Because phase 5 is what is causing a lot of scrutiny, is that the governor is saying he wants a testing, tracing, and treatment. All have to be widely available through the state, either through a vaccine or treatment options are widely available. And as we all know, let's just take the vaccine, for instance, we're still a year to 18 months. The state can't be a year to 18 months to phase 5, realistically, because the state's already broken. It can't take an economic hit waiting that long to go to phase 5. But this is the current plan for the state. We'll see where that comes in. The General Assembly hopefully will have some input on this. I know they have had some input on this. There's been a lot of discussion in the last 24 hours on the plan. But at least, I think, what was it said by, I think it was the Illinois Chamber of Commerce today? They're glad there's a plan even though they don't agree with the plan. So it's at least a beginning. And I think that's how we need to look at this. It's a start. We're kind of uncharted territory, even in some of the emergency preparedness designs for the state was always about how to attack, but not how to bring the state back. So I think this is going to be unusual. It's going to change. We're going to be very fluid. I think what's going to be confusing is just if we get one area of the state that, let's just use it as a wild example, let's say Chicago can't get out of phase 2, but the rest of the state is at phase 4. Or if you have it's going to be very interesting how the state operates if we have a complete imbalance and making sure that we're all at the same level. So I really wanted to spend some time tonight going through that since it just came out yesterday, and I know there's been a lot of talk in the press about it, and wanted to make sure that we at least reviewed it and how it impacts us. So we're going to open up the rest of the time. I know we're according to our time, we got 5 minutes left, but as we all know, we'll go until no one has any questions. So, Jordan, I think your question was there any mentions on how this would be amended? I think it'll just be by action of the governor, and depending on how quickly the General Assembly gets involved with it as well. What disease states are currently being traced by public health, state or community-based operations? That's a good question, Dave. I know that they do a lot of epidemiological tracking on a normal basis through the Sentinel program. I know right now that would still include influenza, and of course it does COVID. I'm not sure what all else that they are tracking. Jordan is saying HIV and STIs are in addition to that as well. And are they capable of all? Well, hopefully they are. But the problem is to get true contact tracing, they're going to need to hire a bunch of people. Now, there are a bunch of unemployed people, but I'm not saying that that's going to be the best population, but they need to be utilizing other aspects of healthcare, whether it's pharmacies. Because I think we can use pharmacies and technicians, we can use students, and kind of help with this. Use some of these nurses and med assistants, dental hygienists, anyone that's not being utilized as much right now, and retask them to help out with this. They're fully trained, they understand how to interview a patient, they know how to protect privacy. Just start letting people have access to a database so they can start inputting this information. And again, it's more about letting the state release control, and that can be a harder thing to do. Maybe I said it could be part of the school curriculum. Yeah, it could be, because it really wouldn't take much to train somebody on how to interview a patient and basically go through the questionnaire. It's not that hard to do. And we're just giving you an update. We're still continuing to, Starlin and I, working with, between ourselves and working with the nationals, still working through all the nuances of trying to come up with testing. And basically the big part is payment and just trying to get some questions answered. Rupesh, you say there's a serious shortage or allocation of basic meds in the market, and if available prices are higher than 500%, if not more, anything we can do to control that? Unfortunately, no, there's not been any movement on pricing controls. And this gets to the main point that I have been telling the governor's office since March was going to be a problem, that we are going to continue to have medication shortages. Doug Higgins and I, working with IPhA and Illinois Hospital Association, have been trying to find ways so that compounding pharmacists can help assist the hospitals in alleviating some of the medication shortages. And we have an ask into the department about probably getting some variances or a guidance document to suppress part of the current recommendations in the Pharmacy Practice Act rules to help compounders to be able to fully assist hospitals right now. I think one thing that we need to push back on our wholesalers is that the wholesalers could push back a little bit in trying to control some of this pricing as well. And they need to be being good stewards of help trying to pressure that as much as they possibly can. And I think that's going to be pushing back from pharmacies back to the wholesalers, because they could push back to the manufacturers. But we recognize that there's a big market swing and that there's no reason for a 500% increase, because we all know what's going to happen then on our side. The Macs are definitely not going to get updated quickly enough, and everyone's going to get screwed over.
I'll just share one example quickly with you. Singular today, it just went up from $35 or less for 1,000 count to $263 at Cardinal.
Right.
And I have a list of almost 40 drugs I can share with you. Every one of them, the price has gone up, and significant.
That would be great, because I've had some conversations about every other week with the wholesalers, so I would greatly appreciate any updated information. That'd be great. Oh, Laura, sorry, I didn't see your hand there. Go right ahead.
I would strongly encourage everyone to attend the Board of Pharmacy and the Collaborative Task Force. It's usually in Chicago at the Thompson Center, and available online is a unique opportunity for everyone to join in. And thank you, Chris, for presenting. Thank you, Garth, for a weekly update. My question, is there any update on our spring legislative session here in Illinois?
Yes and no. The Senate has posted that they may be in session next Tuesday. The House has not posted anything, and someone finally got Madigan to respond to it in the press today, and he said that basically, for the safety of everyone, we need to make sure that we do this safely before we even consider coming back. So it was basically a statement of safety first, but I'm not in any rush.
Yeah, so 2 years from now.
Right.
When we're in phase 5.
Right. So, I mean, we do know that they have to come back, well, best case scenario, so they don't have to really have an extended need for a supermajority. They have to pass the budget by May 31st. So it's kind of like what we've talked about in scenarios. We could see 3 bills, basically. A budget bill, the BIMP, which is the implementation bill, and then possibly an omnibus bill of legislative priorities, like the top legislative priority from each of the departments that has to be done before the end of the budget year, which is June 30th. So it's going to be very interesting. There's been talks of a summer session, mainly by the press. The press have been pushing Governor Pritzker about whether or not he wants to have a special session. He hasn't committed either way. I think there's a lot of work the General Assembly needs to do, whether it's even codifying a lot of what has been done in these executive orders into some type of legislative package, so that there's no question about authority, because that's been a lot of questions in the last number of weeks on lawsuits, whether anything that's being done right now is legal or not. And so a lot of good questions. Well, there's a lot of things that will be going on here in the next coming weeks. Yeah, I can put the meeting information back up on the Board of Pharmacy. Back up, hang on 1 second here.
Can we put that on our COVID site too, Garth? On the
You what?
website?
Yeah, I
Could we
can put
put
it
this-
in our code. Yeah,
Thank you.
no problem. Right, Tom, you bring up a good point. You know, some of the southeastern counties of the state only have 2 to 4 cases. is there any way not to be lumped in with St. Clair and Madison, which both have a couple hundred cases? And I think that's going to be an interesting thing. I mean, you could say the same thing about the central region, because the central region of the state, there's not a lot of cases in a lot of the counties until you get to Sangamon. And most of it is because of our two major health systems here and a nursing home facility that has just exploded with cases. Actually, I think over 30 to 40% of our cases in Sangamon County is from one nursing home. So it's, in the majority of the cases in Christian County, I think over half of those cases are from another nursing home. So it's hard to say. I mean, you could just take easily a nursing home in Mount Vernon or Carmi to explode, and you've got, you know, major case load down in the southeast part of the state as well. So it's going to be hard, and I think this is where they're trying to come up with an idea, at least doing it regionally by these EMS regions, at least for the first draft approach. Any other questions or comments? As always, you guys have a great discussion, so thank you. It helps keep us moving along. And Chris is also saying in some areas, some less populated counties just had no testing sites, which is absolutely correct. And is it possible the numbers are from the counties that these testings took place? And that's true too, because one of the things that we were looking at as a goal from IPHA's point of view is we want at least one pharmacy in every county testing by first part of July if we can get there. But again, that's a very aggressive strategy and goal to obtain, because right now we can get tests, but right now we still can't get personal protective equipment. I was looking online today, trying to see what we could get a hold of for the association, since we're actually considered a CLIA laboratory. And I do want to say congratulations. I don't think either one of them are on here. I don't see them, but I do want to say congratulations to a couple of the pharmacists up in the Chicagoland area that I know wrote some of the very first COVID antibody prescriptions over the last 24 hours. So, and that's one thing to remember, is that we have the ability to order COVID-related tests. And that doesn't just mean the tests that we're providing ourselves. So we're able to provide the COVID test, infection test for a positive or negative, but we can rank for the antibody test. And so that's one thing to keep in mind as well. Jordan was asking, was there an open comment period or anything on the reopening plan? Oh, no, there was no comment period. They said they discussed it with people, but we know it was all with public. They had short phone calls, and you know, we're at the table. I mean, we're working with the governor's office. It's just they're just inundated with everyone right now, and it's just hard for them to go through the normal processes. They're just trying to take a general consensus and look at data and trying to figure out what's the best route. And again, this is, as the governor said, this is the start. This is version 1 of the road back. And well, the question is about how did I find out? I found out they wrote these scripts because they posted on Instagram, and they were actually on that corporate entity's own prescription pads. So. Any other questions or comments? Yeah, I don't see why we can't start writing now. Now, whether or not you can get billed for it, that's the other thing. Cash is always good. As I always say, I take cash and Bitcoin. All right, everyone. I'll let you get back to your evening, and we will see everyone again next week. And again, thank you to Chris for our education component this evening.
Thank you.
And we'll see everyone next week. Be safe. We'll see everyone next week. Be safe.
Bye, everybody. Thanks, Chris. It was awesome.
Thanks, Star.
Yep. We got to talk.
Okay. Bye.
Bye, everybody.